Hi, my name is Professor Dr. Ali Zamir Khan. I am a chest surgeon, a thoracic surgeon. I'm the director of minimally invasive and robotic thoracic surgery at Medanta-The Medicity, Gurgaon, India. And I'm also the director of robotic surgery at St. Bartholomew's Hospital in London, UK. My specialty includes operating on lung cancer, operating on tuberculosis, operating on the esophagus, operating on the diaphragm. So these are all diseases that we see within the chest. And within that domain, I specialize in doing all of these high-end surgeries with keyhole technique, which means a small cut on the chest wall, no cutting of muscles, putting in a camera and doing all these cancer operations to the benefit of the patient. And nowadays, with technology moving on, we've moved on to do almost all of these operations by using a technique called as robotic thoracic surgery, which means it's a robot which we use to dock onto the patient, and I am actually sitting on a console separate from the patient. The advantage of these technologies are that you reduce the cuts on the body, you reduce the inflammation, you reduce the pain, and patients get better faster, they stay less in hospital, and they get back to work quicker. So these are the main domains where I specialize in. I think Indian healthcare industry is on a very, very promising trend. I think we have all the expertise available, albeit it is not organized. So we don't have an organized healthcare system. I'll give you an example. If you look at United Kingdom, in the United Kingdom, we have what is called as a National Health Service. And we have individual specialists working in individual centers, which are tertiary referral centers. So if a guy gets a lung cancer, say in Sheffield, and I am the guy who can offer robotic surgery for this patient will automatically within the system get referred to me, transferred across, and I will operate on him. So the healthcare is available to everybody in the whole country at the same level. In India, that is not the truth. In India, it is a bit of like a lottery system. If you live in a tertiary city, if you live in a high-end city, you have access to corporate hospitals, you have access to good government hospitals like AIIMS, and you might be able to get your lung cancer treated with the highest efficiency. By the same token, if you lived in a smaller city, like say Indore or maybe Ranchi, or maybe in a even smaller city like the village, there is no hope in hell that they will be able to diagnose your condition in time or be able to offer you the correct treatment. So there is a lot of inequity in healthcare within the Indian system. But the expertise of the Indian doctors is very high because they do see a large number of patients. And it is this expertise which is valued overseas and internationally. But within our country, we are not able to use that expertise for the benefit of the population at large, because it is really important. It's not about treating 2 or 4 patients, it's about treating the population at large. And it's not just also about handing the high-end treatment, it's about being able to diagnose the problem. That is a problem with the Indian healthcare, because there is a lot of problems with tuberculosis in India. And if we particularly talk about lung cancer, I think about 70% of the times a lesion on a chest x-ray is missed or misreported as a tuberculosis. And these patients will get treatment for tuberculosis rather than lung cancer. So there are certain issues which we have to address. And I think most of these will be addressed with education. I think the problem here is educating the general public, educating the average family physician, and also educating the specialists, because they need to know who to refer these patients to. So challenges are many. Cost is always an issue in a country like India, where healthcare is an expensive business. But with the new government initiative of providing health care for all at affordable prices, I think the country is heading into the right direction. And I do feel that the Indian government is taking initiatives from countries like Canada and UK to really provide high quality healthcare at affordable prices. And that is the main issue, high quality healthcare at affordable prices. And that is the main trend that I think we need to embrace within the Indian healthcare system. Now, traditionally, when I started training as a cardiothoracic surgeon, the normal access into the chest to operate on a lung cancer would have been a large cut on the chest wall, cutting through muscles, cutting through all the layers, and spreading the ribs wide apart to get into the chest. Also, sometimes we had to make a large cut in the midline and cut through the breastbone to get into the chest. And then we were able to do surgery for lung cancer, which means a lobectomy, which is taking away a lobe of the lung, or a pneumonectomy, which is taking away all of the lung. But with advances and with technology also catching up, all of that now is almost history. Now we make tiny cuts on the chest wall. We dissect the muscles, we do not cut the muscles, and more importantly, we do not spread the ribs. We go between the rib spaces and introduce the instruments and the camera, and we manage to do all the same surgeries that we were doing with an open large cut, and provide the best of healthcare benefit for the patient. The advantage from these tiny cuts is that cosmetically they are better. Pain-wise, they are better because less cut, less inflammation, quicker healing, less pain. The patient is in the hospital for a shorter duration of time. One of the main costs to healthcare is in-hospital stay. If you make a large cut on a chest wall, the patient is in the bed for 7, 8, 9 days before he can even be discharged. With VATS, video-assisted thoracoscopic surgery, you can actually admit the patient in the morning, do the surgery in the afternoon, next morning the drain comes out and he can be discharged home the next day. And so it is that quick turnaround that helps the patient get better. A further advancement of video-assisted thoracoscopic surgery is what is called as a robotic thoracic surgery, which I mentioned earlier. The robotic thoracic surgery, so instead of me scrubbing in to operate on the patient through these tiny holes, I use a robot which has got 4 arms. So what the robot does is I dock the robot through these tiny holes and the robot can move 360 degrees around. My wrist stops here. I can't go beyond that. The robot will go 360 degrees here. It will go 360 degrees here. So you really get an excellent view of the structures that you're operating. Not only is it a magnified view, but it is a 3-dimensional view because the robotic camera has 2 separate cameras fused into one rod. So when I sit on a console, my right eye gets one image, my left eye gets one image, and my brain truly fuses it into a 3-dimensional picture. So unlike in the movie, the 3D movie where the T-Rex is coming to you, here the depth of perception is absolutely accurate down to the millimeter. So, the accuracy of the operation is very, very high. And particularly when you're operating in the chest, around heart and around important blood vessels, around important nerves, you need to be accurate down to the to the last millimeter. Because during these surgeries, the difference between life and death is a millimeter difference, because in 1 millimeter, if you damage a pulmonary artery, you will have 10 liters of blood in your face and the patient will be dead. So robotic surgery actually brings that accuracy to the patient and provides the benefit. And the other benefit, of course, is this is actually a wireless technology. So I could be sitting in India and the patient could be in the UK and I could operate on the patient. So high-end expertise can be available to a patient. So, I don't need to travel to that hospital to provide robotic surgery for them. I could be sitting somewhere else and control the robot from anywhere in the world. And all of this helps to make lung cancer surgery safe, cost effective. And when I use the cost effective, it's very important. The robot itself may be expensive, instruments may be expensive, but the reduced hospital stay actually offsets the cost in a big way for the patient. So eventually, if you compare open surgery versus VATS versus robotic, you will find that the VATS and robotic surgery patients are spending less for the same operation because they are staying less in the hospital. And what about the benefit to the economy at large and the country at large? If you had an open surgery, these guys would be unwell for 1, 2, 3 months before they can get back to work. With robotic surgery, next day or 2 days later, we are discharging the patient. 4 weeks down the road, he's back to his normal life. And so that helps the health economy of the country. It helps the industrial economy of the country, and more important, a lot of our patients depend on their salaries. They cannot afford to be off sick for 3 months, 4 months, 5 months. So it is not just their own lives, but also lives of their families, dependents. A greater picture is there which we have to look at. So robotic surgery and VATS directly impacts every single aspect of the patient's life: health, cosmesis, pain, more importantly recovery, and more importantly the ability to earn a living for the family. So we have to look at the bigger picture when we look at costs. This is my trigger point. I am very, very passionate about teaching people. I trained in the UK for I trained and lived in the UK for 20 odd years. And then in 2010, I came back to India at Medanta to start the VATS and the robotic surgery program. When I first came, everybody discouraged me, saying that in India, tuberculosis is very common. And tuberculosis causes a lot of adhesions to the chest wall. The lung gets stuck to the chest wall. For us to do VATS and robotic surgery, we actually need space between the lung and the chest wall. So almost everybody told me, there is no hope in hell that you would be able to do VATS or robotic surgery. Along the way, we have developed techniques which are specific to the Indian environment, and we have developed training modules for surgeons. So what we did was, we first set up our own department. We proved that we could do VATS and robotics in Indian patients. We proved that we could do in tuberculosis patients. And then what we started doing is what is called as a training program. It was a 4-stage training program where surgeons would come to me. They would first attend a few lectures by us showing our techniques. We would then take them into an animal lab. And Ethicon has been very, very supportive in giving us these access to these sort of training institutes where we take the surgeon in, we make the incision on an animal model, and the surgeon trains to do this operation. That's number one. The next step, after having done that, he comes into my theater and he spends a whole day watching me do the same operation. So that's a double training. After that, he goes back into his own institution, and I travel from my place to his place as a mentor to stand opposite him and take him through these complex operations in his own environment. The one thing that happens, or rather two things that happen when I do this, is A, his confidence goes up because I am there in the room. He knows that if something goes wrong, I can help him through. And more importantly, he starts to believe in his own environment. He believes that this complex surgery, this high-end technology can be inculcated in his own environment. And that is the belief that people need. A lot of people from government hospitals particularly struggle with this belief. They think that high-end VATS or robotics can only be done in corporate hospitals. But what we did was we went out to small hospitals, government hospitals, taught them how to do these surgeries with their own instruments. We designed very cheap instruments for them and gave it to them and said, start doing it in your own setup. So in that process, we, over the 4, 5, 6 years that we were doing these wet labs and training them, we have trained about 250 surgeons in India who are now actively doing VATS. I'm so pleased to know that there is VATS happening in small towns, small villages, small hospitals. Robotic is a different ball game because the initial investment in robotic is very high. So that cannot be implemented at a large scale. That has to still be in a tertiary area. But VATS definitely has reached the smallest tier 3 cities. So that's one way of training people.